Sorry for being late. Actually, I was in another Zoom meeting with a group which included some scientists from US also. So we have, yeah,
Evening,
we
sir.
are at second. Maybe we can start. Dwarika Clinic, you are ready?
Yes, sir, ready.
Good. And you started recording and streaming?
Has sir, just 2 minutes.
Please.
Live stream.
बिना में जो ना मैं लाइव आयो हाय मैं थंबनेल पर सब कर देती हूं
Richa, आपका muted है. Yes,
Good evening, sir. Good evening, Dr. Kapoor, sir. Good evening, Peush, Sahni, sir.
Good evening, Richa. कैसे हो?
Sir, ठीक हो?
Himanshi, please let me know when we can start. Dwarika Clinic.
Yes, sir. Good evening, sir. Please start, sir.
Oh, Avinash, you are there?
Yes, sir. I'm here, sir. Good evening, sir.
Good. Okay. Good evening, everyone, and welcome to the 20th masterclass of Jaipur Surgical Tutorial, or JST as we call it. Jaipur Surgical Tutorial, for those of you who are joining for the first time, is an online education portal that we started now almost 4 years ago at the Mahatma Gandhi Medical College and Hospital. JST is managed by my colleague, Dr. Anand Nagar, who is a professor of HPB surgery and liver transplant with me here at Mahatma Gandhi Medical College in Jaipur. And under the JST, we conduct a weekly session, which is on Saturday morning, 9 to 10 India time, where students, mainly from MCH and DNB, surgical gastroenterology and HPB stream, they present cases which are moderated by the faculty. Sometimes they present an operative procedure also, indications, contraindications, preparation, technique, and complications, again moderated by faculty. And once in a while, we have faculty lectures, especially in related disciplines like radiology, anesthesia, oncology, and others. And almost 1.5 years ago, we started this monthly extension of JST, which is a masterclass. So last Wednesday and Thursday of the month, 7 to 9 p.m. India time, we conduct a single theme masterclass, which is spread over 2 days, so 2 hours into 2 days. And each day we have about 3 presentations by eminent faculty related to that topic. And half an hour is for an open house session where we invite questions from those who are attending live, and the panelists also generate questions with each other. So we've already conducted 19 master classes. In between, I will keep projecting the YouTube site where you can watch these master classes. The technical support for all the JST activities is provided by Dwarika Clinic, which is managed by my former fellow from SGPGI and a consultant GI surgeon in Ahmedabad, Dr. Avinash Tank, and his team. So they record all these sessions and they upload all these videos on the Gastro University YouTube channel, where all these videos are available for free for any student to watch. So we've already conducted 19 master classes on various topics, and today is the 20th, and the topic today is portal hypertension. And I'm very happy that I requested and he agreed. One of the leading GI surgeons of the country, Dr. Peush Sahni, who till recently was the head of surgical gastroenterology at the All India Institute of Medical Sciences in New Delhi, and whose group probably has not only India's, but probably the world's largest experience with surgical management of portal hypertension of various etiologies. And thank you, Dr. Peush, for accepting my request to moderate. Initially, I was thinking of requesting him to make a presentation, but I thought it will be better to have his views on all the presentations and request him to conduct the open house session on both days so that various other aspects which are not covered in the formal presentations are also covered. So thanks, Piyush. And we have three speakers today. Again, the first speaker, Dr. Richa Lal, who's a thoroughbred AIMSonian, MBBS, MS, and MCH from AIMS. And then she was with me in SGPGI for a long time, initially as a pediatric surgical component of the Department of Surgical Gastroenterology, and later she established a separate Department of Pediatric Surgery at SGPGIMS, which is continuing. And I don't think I would be wrong in saying that she probably again has India's one of the largest and probably world's one of the largest experience with management of patients with extrahepatic portal venous obstruction, including their surgical management, because we had a very strong pediatric gastroenterology department, which was established and headed by Dr. Yacha. And both the teams together probably have one of the largest experiences with the patients with EHPVO. So she would be able to give us a very good overview of the philosophy of management of EHPVO. We also have Ragini Kilambi, who is a consultant at the Institute of Liver and Biliary Sciences in New Delhi, and she's going to talk to us about NCPF versus cirrhosis, which sometimes is a clinical dilemma, especially if it is a compensated cirrhosis. And then we will have Dr. Chetan Kantharia, who's the Chief of GI Surgery at the KEM Hospital in Mumbai. He also has special interest and a large experience with portal hypertension. He's going to talk to us about portal biliopathy or portal cavernomatous cholangiopathy, as it is now called. So before, actually, Richa is not keeping well, so she could not prepare a new presentation, but she has sent me a video which she recently probably presented somewhere on EHPVO. We will play that video first, and then I'll ask Richa to add something. But before I do that, I'll request Piyush, Dr. Piyush Sahni, to make some introductory remarks, and then we will play Richa's video. Piyush.
Thank you, sir, for the honor to be a moderator along with you for this session. I think non-cirrhotic portal hypertension is something which needs to be distinguished from patients who have cirrhosis and portal hypertension, because the management of these two conditions is very different. And to lump them all together is being unfair to patients with non-cirrhotic portal hypertension. I think as we go along today and tomorrow, we will hear of the experiences of people who've dealt with these conditions in a very effective manner over a long period of time. Surgical therapy is obviously a good choice in these patients, but there are other modalities of therapy as well, and we would be listening to some of these as we go along. And as we go along, I think I would make more remarks rather than, sort of hog the limelight at the beginning. So I'll stop here and we can start with Richa's presentation. Thank you.
So students, please note that Dr. Piyush used the word non-cirrhotic portal hypertension. Non-cirrhotic portal hypertension is not the same as non-cirrhotic portal fibrosis. NCPF is one of the variants of NCPH, but NCPH also includes extrahepatic portal venous obstruction, and semantically speaking, it may even include Budd-Chiari, although at a later stage, Budd-Chiari would cause cirrhosis. So in the exam also, be very careful, be attentive as to what the examiner is asking. Is the examiner asking about non-cirrhotic portal hypertension, or is the question about non-cirrhotic portal fibrosis? So with that small comment, I will play Dr. Richa's video, and then Richa will make some additional comments, and then we'll have the discussion.
Of endotherapy, what have been the various schools of thought? in decision making on the right surgical procedure in a given clinical scenario, which is governed by the anatomy of the porto-sphenomesenteric venous
Excuse
system,
me, sir, but I can't see the video at my end. Is it
and
visible
an
at
understanding of the
the other?
advantages and limitations of each surgical procedure, wherein I will address the standard portosystemic shunts, the Bezorex bypass, and the debate on standard portosystemic.
Excuse me, sir. I couldn't see the video at my end. Is it visible to the other participants?
I can't see it either.
Good evening. It's not visible. It's only showing sir's desktop and the folder in which your video is there. Not actually showing the video.
At one end of spectrum is approach 1, that is offering total portosystemic shunt.
Is it
for
seen?
every patient.
No, sir.
Endoscopic control of first major bleed episode. At the other end of spectrum is the Baveno 6 guidelines, which recommend a Mesorex bypass not only for secondary but also for primary prophylaxis for every EHO case.
Can somebody please confirm whether it was okay?
Sir, we can't see the video right now.
Okay.
So we can see only our desktop screen. Yeah. Now seems to be something different. Yeah.
And then is a middle path, which is approach 3, which is offering surgical intervention for select indications after endoscopic eradication of gastroesophageal varices. So what determines the most appropriate surgical procedure in a given clinical scenario? It is the anatomy of the porto-sphenomesenteric venous axis, the indication for surgery, and an understanding of the advantages and limitations of each surgical procedure. And I will address the anatomy first. Now, for distribution of venous thrombosis, I will refer to all of series of 200 consecutive cases of EHO, wherein the portal vein alone was involved in 70%. In 25%, there was concomitant involvement of either the splenic vein or the superior mesenteric vein. And in 10% cases, the entire SPV axis was thrombosed. So when planning for surgery, the pre-op imaging begins with an ultrasound with color Doppler.
It's not, the slides are not moving at this end.
Accuracy in defining a portal cavernoma, followed by a CT or an MR portoveinogram. A wedge hepatic venous photography is indicated when a Mesorex bypass is being planned, and MRCP is indicated in select cases for mapping of biliary anatomy. So after a screening ultrasound Doppler, a CT or an MR portoveinogram reconstruction is a very good tool for precise definition of the anatomy of the two limbs of any shunt. The afferent limb, which is a tributary of the portovenous system, and the efferent limb, which is a branch of the systemic venous system. So in the afferent limb, one would like to assess the shuntability, which is defined by adequacy of diameter, adequate length, and regular lumen of two major veins, namely the splenic vein and the superior mesenteric vein. Adequate diameter usually refers to more than 5 mm, but this would vary with technical expertise. Adequate length, especially for superior mesenteric vein, the infraduodenal segment is important because this is the place where the graft is placed. Regular lumen, meaning thereby that this should not be a partially thrombosed vein because a vascular anastomosis with a partially thrombosed vein is unlikely to sustain patency. Further, a patent confluence of the superior mesenteric vein with the splenic vein signifies a favorable anatomy because it indicates that a portal decompression with either the SMV or the splenic vein would decompress all compartments of the valvulus portal venous system. On the efferent limb, one would like to exclude variations in the anatomy of the left renal vein and left kidney. So examples of variant left renal vein anatomy are a retroaortic left renal vein, which restricts length available on the anterior surface for anastomosis, and a bifid left renal vein. And in these situations, in our experience, we have to take recourse to a splenoadrenal shunt. Moreover, the left kidney may be absent or atrophic. It may be ectopic, say a pelvic left kidney or a crossed fused renal ectopia, or it could be a horseshoe kidney. And in each of these situations, a splenorenal shunt may not be technically feasible, and therefore one has to plan an alternative procedure wherein the outflow is drained into the inferior vena cava. For a Mesorex bypass, The extrahepatic portal venous anatomy is assessed on an abdominal CT or MR portovenogram. The intrahepatic portal venous anatomy is assessed on a wedge hepatic venous protogram. And a Doppler ultrasound of the neck is done to assess bilateral internal jugular veins because these are the most robust and popular veins used for a graft. So for a mesorex bypass on an abdominal CT, one confirms the adequacy of the diameter and length of the infraduodenal segment of the SMV and the patency of the confluence of the superior mesenteric vein with the splenic vein. However, the limitation of an abdominal CT is its poor sensitivity in defining the anatomy of the left portal vein in the recess of legs. Because the left portal vein is often hyperplastic in these children, the prograde portal perfusion is poor and the anatomy of the recess of legs is masked by hilar collaterals. So, the gold standard for imaging of intrahepatic portal venous anatomy is a wedge hepatic venous portography, which is performed by a transjugular retrograde route, meaning thereby that the right IJV is cannulated, the tip of the catheter is advanced into the left hepatic vein, contrast is injected, and this opacifies the entire intrahepatic portal venous system.
So again, the video is
MRCP is indicated in select cases with symptomatic portal cavernoma cholangiopathy or those that are asymptomatic but there is concern because of persistently raised liver enzymes, especially GGT. So what is PCC? It is important to be aware of this entity and to recognize it early. The Indian National Association for Study of Liver defines portal cavernoma cholangiopathy as abnormalities in the extrahepatic biliary system, including the cystic duct and the gallbladder, with or without abnormalities in the first and second generation bile ducts in a patient with portal cavernoma. So the cholangiographic changes are indentation and irregular ductal contour because of compression by high pressure epicholectocal and paracholectocal collaterals, CBD angulation because of displacement by a cavernoma here. Fortunately, these changes may reverse following portal decompression surgery. However, over a period of time, ischemia and fibrosis occur because of prolonged compression, deprivation of portal blood flow, and encasement by fibrous cavernoma. And this results in a fixed stricture with proximal dilatation, and this is unlikely to reverse following portal decompression alone. Now, after having assessed the anatomy comes indication for surgery. Now, endotherapy leads to obliteration of natural portosystemic collaterals, but portal pressures continue to be elevated. And these could manifest in the form of exacerbation of isolated gastric varices, ectopic varices, vasculopathies, namely gastropathy, entropathy, and colopathy, issues related to splenomegaly and portal cavernoma cholangiopathy. So indications for surgery in era of endotherapy could be divided into bleed-related indications and non-bleed indications. Now, bleed-related indications are those wherein endotherapy has failed or the varices are not amenable to endotherapy. And these are isolated, large gastric fundal or enteral varices, ectopic varices, or vasculopathies. So what are ectopic varices? Ectopic varices are those which are sited distal to the stomach, which means duodenum, small bowel, anorectal region, biliary tree, any sites of anastomosis or stoma. So when they bleed more torrentially. They are obviously difficult to control by endoscopy and therefore have a higher mortality. And hence, ectopic varices warrant an early surgery. Of non-bleed indications, the commonest is splenomegaly-related issues. This could be in the form of clinically symptomatic hypersplenism, the commonest manifestation of which is menorrhagia in adolescent girls. In extreme cases, there could be spontaneous bleed in the skin or nose or gum, etc. Or there could be a splenic infarct, which could evolve into a splenic abscess, which is a challenging problem, especially in the setting of EHPVO. Then a large subset of patients have massive splenomegaly with asymptomatic but severe hypersplenism, wherein we define severe hypersplenism as platelets less than 50,000 and TLC less than 2,500. And this leads to significant impairment of quality of life because of chronic pain, early satiety, restriction of physical activity, etc., and therefore merits surgery. Now, when does portal cavernoma cholangiopathy become an indication for surgery? When it is symptomatic in the form of jaundice, pruritus, pain could be because of gallstones or CBD calculi or cholangitis, or when it is clinically asymptomatic but of concern because of persistently elevated liver enzymes. And it is important to intervene at this stage and not wait for it to evolve into symptomatic or complicated PCC. Now, we need to understand that primary intervention on the biliary system without prior portal decompression in EHO is fraught with risk of life-threatening hemorrhage because the CBD is encased with numerous high-pressure collaterals. The strictures are multiple and often high and hilar in location and therefore difficult to access by surgery. So portal decompression surgery plays a key role in the surgical management. It relieves biliary obstruction in as many as 60 to 70% of cases. In others, it renders biliary surgery safe by decompressing high-pressure collaterals. Now, after anatomy and indications, the final decision is based on an understanding of the advantages and limitations of each surgical procedure. So, surgical procedures for EHO are classified as portosystemic shunt procedures, which could be total or selective. A mesenteric left portal vein bypass, which is actually not a shunt but a portal reperfusion procedure, and gastroesophageal devascularization. Now, total shunts are so called because they effectively decompress the entire portal venous system, and in doing so, they completely divert all portal flow away from the liver. They have been the most popular shunts for EHO so far because they have low rebleed rates and they take care of issues related not only to gastroesophageal varices but also those related to large spleen, ectopic varices, portal cavernoma cholangiopathy, and they also enhance growth. So total shunts are either splenorenal shunts or mesocaval shunts, and a splenorenal shunt could either be a splenectomy with central end-to-side splenorenal shunt or a spleen-preserving side-to-side splenorenal shunt. And I will go over the advantages and limitations of each. So the advantages of a splenectomy with central end-to-side splenorenal shunt is that it eliminates all issues related to massive splenomegaly affecting quality of life adversely. But its limitations are that it has a relatively higher incidence of shunt block because of angulation at the site and post-splenectomy thrombocytosis. Angulation can occur either because there is a twist in the lie of the vein or because of an over-enthusiastic splenic vein mobilization and hence redundancy. Splenectomy increases the operating time and blood loss because splenectomy in EHO is a challenging procedure. There is a small but a definite risk of post-splenectomy sepsis, especially in children younger than 9 years of age. And it is not a very ideal procedure when splenic vein diameter is less than 5 millimeter. So we would offer this procedure when the primary indication for surgery is massive splenomegaly affecting quality of life adversely with or without other sequelae of portal hypertension, preferably with a good diameter splenic vein more than 5 millimeter. On the other hand, a side-to-side splenorenal shunt offers the advantage that it permits a wider diameter vascular anastomosis with a relatively smaller diameter splenic vein, which means that with a 5 millimeter splenic vein, one can fashion a vascular anastomosis of around 11 to 12 millimeter. There is lesser risk of angulation or twisting because the splenic vein is securely anchored at both the ends, and it is a spleen-preserving shunt. So while it is effective for mild to moderate splenomegaly, its limitation is that it is less effective for massive splenomegaly with severe hypersplenism. And in older patients, say older adolescents or young adults who have thick retroperitoneum with wide separation between the splenic vein and the renal vein, approximating these two veins may present a technical challenge. So we would offer the shunt when there is absence of significant issues related to massive splenomegaly and severe hypersplenism. And in a small diameter splenic vein, a side-to-side vascular anastomosis would have an advantage over a end-to-side vascular anastomosis. Mesocaval shunt, its advantage is lesser angulation as compared to a central end-to-side splenorenal shunt, and of course it is a spleen-preserving shunt. But again, the limitation is that it will not be effective if the patient has issues related to massive splenomegaly and severe hypersplenism. So again, one would opt for the shunt when there is absence of significant issues related to spleen and when there is a good diameter and length of intraduodenal segment of SMB. Now, selective shunts are so called because they selectively decompress one compartment of the portal venous system, and the example of which is a distal splenorenal shunt. So, in distal splenorenal shunt, the splenic vein is disconnected at its junction with the SMV and anastomosed to the renal vein. So, a selective shunt compartmentalizes the portal venous system into a decompressed gastrosplenic circuit, but the superior mesenteric circuit continues to be hypertensive and maintains prograde portal perfusion. And by doing so, selective shunts take care of concerns which are related to liver being deprived of all portal perfusion following total shunts in CLD, that is post-shunt liver decompensation and encephalopathy. But there are certain limitations of selective shunts, especially with reference to EHO. It is a spleen-preserving shunt. It would take care of issues related to mild to moderate splenomegaly, but issues related to massive splenomegaly could persist. Moreover, the superior mesenteric circuit continues to be hypertensive, and therefore a selective shunt is not effective in decompressing ectopic varices or portal cavernoma cholangiopathy. And for these reasons, a selective shunt has not been very popular for EHO, especially in India, wherein patients present with massive splenomegaly often. Now, a mesenteric left portal vein bypass represents a paradigm shift in the philosophy of management of EHO. It essentially entails placement of a graft between the superior mesenteric vein and the left branch of the portal vein in the recess of Rex, and therefore it is a portal reperfusion procedure with a curative approach. So what is the relevance of a mesenteric left portal vein bypass in EHO, wherein the liver architecture and function are presumably normal? And for that, let's look at the consequences of EHO. One, that it leads to portal hypertension. Two, the liver is relatively deprived of portal perfusion, which carries hepatotrophic factors for a long time. And this manifests as coagulation abnormalities like raised INR and impaired liver growth. It also opens up natural portosystemic shunts, which allows several enterotoxins, especially ammonia, to bypass hepatic degradation and enter the systemic circulation. This leads to low-grade cerebral edema and could manifest as minimal hepatic encephalopathy. So the next question is, do total shunts predispose to encephalopathy in EHO? So there are several landmark surgical series which have reported a zero overt encephalopathy following total shunts in EHOs. But studies in the last 2 decades have raised concerns about the possibility of minimal hepatic encephalopathy in the form of mild neurocognitive defects, which means that the parents can report that there is a change in the child's attention span or memory, and hence a decline in his school performance or a change in temperament or sleeping pattern. So a mesorex bypass is conceptually a curative procedure because it restores hepatometric blood flow. By doing so, it corrects deranged INR, it reverses minimal hepatic encephalopathy, and it improves liver and somatic growth. So while mesorex bypass is conceptually the ideal procedure, the important questions are, what are the prerequisites? How often is it realistically successful? And what are the postoperative issues? And let's look at the answers. So anatomical prerequisites for a mesorex bypass are those pertaining to the extrahepatic and intrahepatic venous anatomy. And a favorable extrahepatic splenic venous anatomy refers to an adequate diameter and length of the infraduodenal segment of the SMV together with a patent confluence of the SMV with splenic vein. But more important is the intrahepatic portal venous anatomy. And for that, I would refer to this very meticulous study by Dr. Deville de Goya's group, wherein the intrahepatic portal venous anatomy was studied on the basis of wedge hepatic venous photography performed on 89 consecutive children, and 5 subtypes of intrahepatic portal venous anatomy were described. And a favorable intrahepatic portal venous anatomy, which would permit a successful mesorex bypass and also ensure its long-term patency, was defined as a type A anatomy. And what is a type A anatomy? It refers to patency of the entire intrahepatic portal venous system with good diameter, regular contour, patent confluence, and hence a good communication between the left and the right system. And how often do we get a favorable anatomy? Mind you, it is only 29% of all EHO cases evaluated by wedge hepatic venous photography. Then what are the post-surgical issues? There is a greater need for post-bypass endovascular or surgical intervention procedures to sustain bypass patency, reported to range from 17% from Dr. Supirana's group to 28% by Guarantor. The site of stenosis is usually the junction of the graft with the left portal vein. Because the left portal vein is hypoplastic, the prograde portal perfusion is poor. There is a little angulation because of a posteriorly placed anastomosis, and the graft may also get compressed because of overgrowth of adjacent living parenchyma from segment 3 and segment 4. Moreover, a mesorex bypass is not the most important procedure when massive splenomegaly-related issues, like clinically symptomatic hypersplenism or a painful splenic infarct, adversely affect quality of life and form the primary indication for surgery. So let us compare the results of conventional shunts with the mesorex bypass. Conventional shunts in experienced hands, elective surgery has been reported to have zero mortality. An emergency shunt has a higher mortality. Shunt thrombosis rates have been reported to range from 2.5% to 13%. Mesorex bypass, number of cases and duration of follow is shorter. Shunt thrombosis rates are reported to range from 8% to 18%. But this is after several of these grafts have been salvaged by endovascular intervention in the early postoperative period. So obviously, these are higher as compared to conventional portosystemic shunts. Now, where does gastroesophageal devascularization have a place? In the elective setting, one would always prefer a shunt over a devas, but a surgeon may be forced to take recourse to a devas when the anatomy is not shuntable, but surgery is necessary for bleed from large isolated gastric varices where an endotherapy has failed with or without significant splenomegaly-related issues. On the other hand, when the indication is emergency surgery for uncontrolled bleed, one may opt for an emergency devas over an emergency shunt because the mortality of an emergency shunt is higher than that of an emergency devas. Its limitation, however, is its higher rebeat on long-term follow-up. And because the portal pressures continue to be high, these children could manifest with ectopic varices or portal cavernoma cholangiopathy on long term. So a suggested algorithm based on anatomy and indications is as follows, that when the indication for surgery is variceal bleed or symptomatic portal cavernoma cholangiopathy, but there are no significant splenomegaly-related issues and the anatomy is shuntable, then one would prefer a spleen-preserving procedure, which could be a mesorex bypass if the anatomy is favorable, or a distal splenorenal shunt, depending on one's philosophy, or it could be a side-to-side splenorenal shunt or a mesocaval shunt. On the other hand, when the indication for surgery is a massive spleen, which is affecting quality of life adversely, with or without bleed or PCC, and the anatomy is shuntable, then one would elect to do a splenectomy because here splenectomy is contributing to most morbidity and concomitantly combined with the shunt. In the post-op management, the important points are anticoagulation, shunt patency assessment, and prophylaxis for post-splenectomy sepsis. Now, anticoagulation, unfortunately, there is lack of consensus and uniform protocol across different centers in the world. We would give intraoperative heparin, 100 international units per kg, just before applying vascular clamps, continue heparin till day 7, followed by oral aspirin for 6 months. For shunt patency, we would do a Doppler on post-op day 7, followed by a 6-monthly Doppler for 2 years and a yearly Doppler thereafter. If we cannot visualize the shunt on Doppler, we would do a CT portovenogram. We would do one upper GI endoscopy at 6 months following surgery, after which, if the shunt is patent, no further endoscopies are needed. Other indicators of well-functioning shunt are downgrading of varices at endoscopy 6 months post-surgery, and in spleen-preserving shunts, improving hemogram and regressing splenic size are good surrogate markers of well-functioning shunt. Post-splenectomy prophylaxis, again, the protocols vary. We would immunize our children for pneumococcus, meningococcus, and H. influenzae, and also give post-op amoxicillin prophylaxis for 2 years. So I'll conclude by saying that a mesenterical left portal vein bypass is conceptually an ideal portal reperfusion procedure. However, the caveats are that it's technically feasible In a small subset with favorable anatomy, reported to be 29% based on wedge hepatic venous photography, there is a greater need for post-procedure endovascular reintervention, reported to range from 17 to 28%, and it is not the most appropriate procedure when massive splenomegaly predominantly affects quality of life adversely. And therefore, for a large subset of remaining patients with anatomy and indications not favorable for a mesorex bypass, the standard portosystemic shunts continue to hold a valuable role. And hence, a surgeon needs to have a wide spectrum of procedures in his or her armamentarium to be able to provide the best option to a given patient tailored to the anatomy and indications. Thank you very much.
Thank you, Richa. I think we'll take the questions related to portal cavernomatous cholangiopathy after Dr. Chetan Kantharia also has made his presentation. But one question which is very frequently asked of the students in the exam is the relationship between EHPVO and growth retardation in children. So a word about that. And then what is it which can reverse growth retardation? Is it splenectomy or is it shunt? And third, up to what age you can give the parents an assurance that if we do a surgical procedure, there may be a reversal of growth retardation?
So, sir, thank you for that question. The factors that contribute to growth retardation in EHPVO are one, a large spleen, which leads to chronic pain and early satiety, and therefore decreased appetite in these children, and chronic anemia, again because of hypersplenism. And these children may also have portal hypertensive enteropathy. And another etiological factor which has been hypothesized is that because the liver is deprived of prograde portal perfusion, there is resistance to growth hormone and there is deficiency of insulin-like growth factor. Now, when we do the splenectomy with the central end-to-side splenorenal shunt, we take care of all the problems which are related to a huge spleen, that is early satiety, chronic anemia. By doing a shunt, we decompress the portal venous system and therefore we take care of portal hypertensive enteropathy. And we have seen that there is a very significant improvement in growth retardation following splenectomy and end-to-side splenorenal shunt. At the same time, as you rightly asked, sir, that patients who have a non-shuntable anatomy, but they have a very huge spleen and their quality of life is significantly impaired because of splenomegaly, and they have chronic anemia because of severe hypersplenism, and we have done splenectomy with gastroesophageal devascularization in those patients. Those patients also have shown a significant improvement in growth retardation. And in fact, this lecture I had prepared before we published our own data. I mean, we published our 20-year experience in Journal of Clinical and Experimental Hepatology 2023. I can cite the reference in the chat box if others find it useful. So in that paper, we had shown that the improvement in growth Z scores pre-surgery and post-surgery were equivalent in patients who underwent total shunt and in patients who underwent splenectomy with devascularization. So a huge spleen definitely contributes contributes to growth retardation to a very large extent. Now, having said that, sir, patients coming with a huge spleen has a problem which is very specific to India. Now, if we read about groups who practice mesorex bypass and are strong proponents of mesorex bypass, and these are the patients where splenomegaly is not an issue. There also, there is a significant improvement in growth. In fact, there the liver size also improves. And there actually, the restoration of prograde portal perfusion to the liver plays a major role in reversing growth retardation. So I hope that the first part of your question I've been able to answer. As far as the age is concerned, I think the right time to take action if we need to ensure that the patient will have good growth is before puberty, before the epiphyses have fused. So if you kind of do the procedure before the epiphyses are fused, these patients, they kind of can benefit with the, have the advantage of reversal of growth retardation.
Piyush, please. Dr. Piyush?
Yes, sir.
Yeah. Any comments? Otherwise, you can.
Yeah, so our approach is slightly different to a number of these issues. So prophylaxis, we don't do prophylaxis. The paper Prasad et al., which Richa showed you, is our experience. A very small number of patients with overwhelming postplanectomy infection. I quite understand the concern of a pediatrician and a pediatric surgeon. And I can tell you that we had a patient whose mother was a pediatrician, and she insisted that she wanted to use prophylaxis, and we said, please go ahead. But as a rule, as a routine, we did not use prophylaxis. Anticoagulation is something that we don't use, and that's possibly because our anastomoses are wider and they're in adults. And what we found is that our shunt thrombosis rates are much higher than our rebleed rates. So our rebleed rates are in the range of 10%, but our shunt thrombosis rates are higher. And one of the reasons we do not do, a very intensive follow-up in the postoperative period looking at shunt patency is primarily because of this, because only half the patients with a blocked shunt will rebleed. And our main indications for surgery in most of these patients is a variceal bleed. They may have other indications along. They may have a large spleen. They may have growth retardation. They may have portal biliopathy. I still prefer to call it that rather than portal cavernoma cholangiopathy, because the name suggests that can occur only in patients with extrahepatic portal venous obstruction. And while there is definite evidence of the fact that can occur in patients with non-cirrhotic portal fibrosis as well as cirrhosis, and the management is largely similar, and therefore calling it PCC restricts it to one group of patients with non-cirrhotic portal hypertension. Even if we say that in cirrhotics, we rarely, if ever, intervene for portal biliopathy. So our approach is slightly different. Our experience with trying to look for a patent left portal vein, though I confess it was only on Doppler ultrasounds, was quite poor. We looked for, and these were all adult patients, so it's possible that those hyperplastic portal veins in young children actually get blocked over a period of time because of the low flows and the diversion of blood into collaterals. What exactly causes the growth, the reversal and the growth spurt after a DVASC or a shunt is anybody's guess. Hepatotrophic factors obviously don't play a role there, because this growth spurt happens even if you divert more blood away from the liver. And therefore, we're all still not very clear as to why this growth spurt happens, but there's no doubt that the growth spurt happens. Encephalopathy rates should be higher if these patients were to suffer from a large diversion of blood flow away from the liver. And in adulthood, we should start seeing some patients with encephalopathy. We described subclinical encephalopathy and reported it, published a paper on it in the British Journal of Surgery. A very low incidence of subclinical encephalopathy. The concept of minimal hepatic encephalopathy came much later. There was this concept of subclinical encephalopathy, and it does occur in patients with extrahepatic portal venous obstruction as well as in non-cirrhotic portal fibrosis, more in non-cirrhotic portal fibrosis than in extrahepatic portal venous obstruction. But we didn't come across anybody who was incapacitated because of this. Now, it's possible that we did not look carefully enough, but these children grew up to become adults. Some of them had children, some of them got married, and we did not come across any major issues in these people. We have had two instances of someone telling us that we encountered a patient whom you'd done a shunt on, and the patient presented to us with encephalopathy. Unfortunately, we did not, they did not have the name of the patient or the discharge summaries or whatever, and therefore we could never corroborate this. But we've had two instances of people who have told us that on follow-up, they've seen patients of ours who have had encephalopathy. So whether we did get patients who developed encephalopathy over a long period of time, even if there was a number, it was a very small number. So I'll stop here and we can.
Thank you. Thank you. Just one more kind of tip or caution for the students. In the Beveno classification, EHPVO has been used for portal vein thrombosis in adults caused by other conditions like pancreatic diseases, biliary pancreatic malignancies also. But by and large in India, when we say EHPVO, we mean what Dr. Richa has presented. So be a little careful on this. Some examiners may kind of confuse you on this. You should be clear. Ragini, you can start sharing your screen. You can put your video on. So next speaker is Dr. Ragini from ILBS, and she's going to talk to us about NCPF versus cirrhosis. And as I said, this sometimes becomes a clinical dilemma, both in exam and in clinical practice, especially if it is a compensated cirrhosis. So Ragini is going to tell us about that.
Good evening, sir. So thank you for this introduction and opportunity. So the next talk is on NCPF versus cirrhosis. This we'll first look at what is NCPF in the first place. Why should we differentiate it from cirrhosis? Something which Dr. Peush has already alluded to in the beginning. Then we look at how do we go about differentiating it from cirrhosis. And then finally, are there actually two distinct mutually exclusive entities or not? So to begin with, portal hypertension, which is the topic for today and tomorrow, is basically increased portal pressure. The most common cause of which is cirrhosis. However, there are patients without cirrhosis who would have portal pressure, high portal pressures. This could be either extrahepatic, which would include the EHPVO, which Madam spoke about, or Budd-Chiari syndrome, other causes, and intrahepatic causes. In the intrahepatic causes, you have certain identifiable etiologies like schistosomiasis, veno-occlusive disease, amyloidosis, congenital hepatic fibrosis, etc. And then there is a group of diseases where the etiology is not evident, and this is what has been termed as non-cirrhotic portal fibrosis or idiopathic portal hypertension, and this is what we will be focusing on in the next half an hour. So when we talk about non-cirrhotic portal fibrosis, this is basically a form of non-cirrhotic portal hypertension. It results in increased portal and splanchnic pressures due to resistance in the portal circulation without the presence of liver cirrhosis and with a patent portal vein. Now, if we look at literature on non-cirrhotic portal fibrosis, we find that there is a lot of confusion because of the number of nomenclatures that are there, as well as you see that these nomenclatures differ mildly in their etiologies and demography. So while in Japan, this is termed as idiopathic portal hypertension, the West labels it as idiopathic non-cirrhotic portal hypertension, hepatoportal sclerosis, or obliterative venopathy. A new terminology called as portosinusoidal vascular disorder has recently been proposed by Europeans about 5 years back. But all in all, essentially, they are all referring to the same condition, which in Indian subcontinent is termed as non-cirrhotic portal fibrosis with mild differences. So if we look at the definitions, APASL in its updated 2024 guidelines defined NCPF as a condition of varied etiology, typically manifesting as portal hypertension in the absence of EHPVO or specific known causes like of cirrhosis or schistosomiasis, and it's characterized by narrowing or loss of small and medium branches of portal vein that result in the development of portal hypertension. Idiopathic portal hypertension is basically a disorder of unknown cause, again, characterized by splenomegaly, anemia, and portal hypertension in the absence of cirrhosis, blood disease, parasites, occlusion of portal and hepatic veins, granulomas, congenital hepatic fibrosis, and other unknown diseases. INCPH is defined as a disorder with increased portal venous pressure in the absence of cirrhosis and a patent portal and hepatic vein. These are the simple definition. PSVD is defined as absence of cirrhosis in a liver biopsy with the detection of specific or non-specific histological findings with or without portal hypertension. So how PSVD differs from the other three is that they have included those patients which who probably are in the very early phase of the disease when they have not developed portal hypertension, while for the other three, the presence of portal hypertension is mandatory for making a diagnosis. If we look at epidemiology, this is a disease that is like EHPVO, that of the developing world, seen less often in developed countries, and therefore poor socioeconomic strata is believed to be one of the factors responsible for this disease. The typical patient is a male, young male in the 3rd to 4th decade of life. The data from Japan, however, suggests that it is more common in females and thus like a decade older in their presentation. The most common presentation being that of variceal bleeding. Now, the important thing about etiology, as we have seen in the definition itself, is that the etiology is varied and often unknown. So several etiological factors have been put forth as possible. The most commonly cited etiological factor is infections. It is postulated that patients who have repeated childhood infections in the form of diarrheal diseases or umbilical sepsis will have repeated septic small embolic showers into their portal veins, which results in the sclerosis of the small and the medium-sized portal venules. This basically triggers the thrombin and the cytokine cascade, results in the activation of the stellate cells and deposition of fibrin, resulting in NCPF. Also, the factor that goes into in favor of infection is the fact that today NCPF is being reported in lesser and lesser numbers from all over, considering there have been improvements in levels of hygiene, improved perinatal care, and reduction in the rates of childhood infections. Another important etiological factor is a prothrombotic state. Often patients with NCPF have been found to have some associated prothrombin state like an antiphospholipid antibody deficiency, low levels of protein CS, or hyperhomocystinemia. Another important, interesting etiological factor is exposure to toxins. It has been seen in epidemiological studies that the distribution of NCPF seems to mirror that of areas where there is arsenic contamination of drinking water. Drugs like antiretroviral therapy, oxaliplatin, diagnoside, etc. have also been known to produce an NCPF-like picture. Another interesting observation is that these patients also have associated autoimmune diseases like rheumatoid arthritis and SLE, and autoantibodies are seen in circulation of patients with NCPF. So patients with NCPF also are at a risk of developing glomerulonephritis. And it was seen that this is again data from AIMS, that glomerulonephritis, which was seen post-shunt in patients with NCPF, actually was consisting of IgA immune complexes. And it is possible that the same immune complexes are actually responsible for NCPF, which are actually now presenting as nephritis. The familial clustering and associated with specific HLA types like DR3 could be because of some genetic basis to this disease. However, these are all postulated and nothing is proven. But what appears is that there seems to be varied etiology in different patients, and therefore this may actually be a basket of patient cases which result in a similar eventual manifestation rather than a single disease. This is a pictorial representation of the same, showing presence of prothrombotic tendency along with repeated infections results in obliteration of small and medium-sized portal venules. The Japanese proposed the endothelial mesenchymal theory, where they stated that there is the change in the endothelial cells morphology to myofibroblast cells, like cells which then lay down the collagen, which results in obliterative venopathy and pre-sinusoidal portal hypertension. If we look at the pathology, grossly these rivers may either appear normal or enlarged, the so-called beefy liver of NCPF. They may also have a nodular appearance or may sometimes be shrunken. The surface may be smooth, wrinkled. If you have nodular regenerative hyperplasia, they could have pale, small nodules on the surface as well. The autopsy specimens have shown that the capsule is thickened with subcapsular septations and intrahepatic portal venous sclerosis. There is thickening of the walls. Now, what is interesting to note is that even when nodules are seen on patients with NCPF, they are not actually because of the encircling fibrous septa, as in a case of cirrhosis, but is actually the portal deprivation which leads to atrophy of the hepatocytes, which then appear like a plate, and then hyperperfusion in the adjacent area leads to hyperplasia, and that hyperplasia gives this alternating atrophy and hypertrophy gives the appearance of a nodule. If we look at clinical features, a proportion of patients may be asymptomatic, diagnosed only after evaluation for routine tests showing thrombocytopenia or splenomegaly, but the vast majority of patients do present with some or the other feature of portal hypertension. Splenomegaly is seen in almost all patients, but what is classical is that these patients have a massive splenomegaly in contrast to that seen in cirrhosis or even for that matter EHPVO. So with such a large spleen, symptomatic hypersplenism, either with pain or dragging discomfort or hematological picture of anemia, leukopenia or thrombocytopenia is common. Most of these patients will have gastroesophageal varices, and even rectal varices are common in most of these patients. When we look at upper GI bleed, so third of patients will actually present with upper GI bleed, and almost 85% will have one episode of GI bleed in their lifespan. And this is the most common presentation. But what is interesting is that these episodes of bleed are generally very well tolerated, similar to what you see in patients with EHPVO. But as the patients age, there is a higher chance, if they have not bled, that they would go on to bleed, or they will rebleed if they have not been subjected to some treatment for the varices. Ascites is not uncommon in NCPF, but is usually transient and is associated with an episode of bleed. Could be possible because of overaggressive resuscitation, but in the absence of bleed, a standalone ascites portends a very poor prognosis. Minimal hepatic encephalopathy, like already alluded to in recent studies, we've seen in nearly a third of patients, but overt encephalopathy without any intervention is rare and is seen in less than 1% of patients. If we talk about diagnosis of NCPF, we don't have definitive criteria. What we get from most definitions is that you have to have portal hypertension, cirrhosis should not be there, and you should have a patent portal and hepatic vein. But other than this, there isn't any strict criteria for it. But how do you go about suspecting that a patient has got NCPF or your idiopathic portal hypertension? If you have an unexplained splenomegaly, or if you have an episode of variceal bleed but no other hepatic decompensation, portal hypertension but the liver functions seem to be well preserved, there is no cirrhosis, or if you just have an altered liver function test without any other abnormality, you can suspect NCPF as the underlying disease. If we look at lab findings, in a complete hemogram, almost all patients will have some anemia and thrombocytopenia and leukopenia. Even presence of a suppression of a single cell line is sufficient to make the diagnosis of hypersplenism. Liver function tests may be normal or just mildly deranged. Jaundice is not common, but however, if there is a lot of hemolysis happening, indirect hyperbilirubinemia may be seen. Mild derangements in transaminases may be again seen. Mildly elevated INR is also something that can be seen because of a low-lying level of DIC, which is seen in patients with NCPF and EHPVO also. If we talk about imaging, Doppler ultrasound, this is not something that we generally are very conversant with by reading ourselves, but at least the features that we are supposed to see, we should all be aware of. So first and foremost, one is going to see a patent and a dilated portal vein in NCPF along with an enlarged spleen. What you see is there is abrupt narrowing and cutoff of the intrahepatic second and third degree portal vein branches, giving rise to what is called as a withered tree appearance or peripheral pruning. This is something that will be much more easy to visualize on the CT, which we'll be seeing subsequently. You may also see spontaneous shunts, and the portal vein wall is thickened. So this is an ultrasound image. You can see that this is a portal vein with significant portal vein wall thickening more than 3 millimeters. If we talk about CT, again, the typical non-visualization or narrowing of the intrahepatic peripheral portal vein branches. Because of this deprivation, there may be some amount of volume redistribution with right lobe atrophy. So this is the non-contrast image of the CT that is showing you splenomegaly along with these calcified specks that you are seeing, which represents the gamma antibodies. So when there is portal deprivation, there is arterial hyperperfusion. So you get these areas of arterial enhancement in the arterial phase. These vascular changes also lead to frequent appearance of focal nodular hyperplasia like nodules. So this enhances early in the arterial phase and continues to retain contrast in the portal venous phase because it basically is made up of functioning hepatocytes. Now, this is how a withered tree looks like. So you can see there's an abrupt change in the caliber of the branches. If you look at the CT, this is the left portal vein, and there's an abrupt change in the caliber of the portal vein branches here. And this is what is called as a peripheral pruning or the withered tree appearance. Now, this is a CT image where you can see that the right lobe is atrophic, the caudate lobe is hypertrophic, and there is a left lobe also is hypertrophic with some amount of volume redistribution. The overall liver volume appears to be preserved, but there is a redistribution. When you come to advanced stages, it may become very difficult to distinguish from cirrhosis once the liver is shrunken and there is an irregular outline. Also, a significant number of these patients in the later stages would develop portal vein thrombosis, though a cavernoma may not be seen. So this is a CT which is showing you portal vein thrombosis with calcification, but sometimes long-standing portal vein thrombosis may result in a cavernoma formation when, unless you have a previous imaging, it may become very difficult to distinguish between NCPF with a portal cavernoma versus an EHPVO. This is a CT picture of the same. which is here. Now, this is interesting because this is an 11-year-old kid, so you don't see all the features, but you can still see the peripheral pruning. You can see some amount of right lobe atrophy setting in, but the caudate lobe is not hypertrophied here. The spleen is enlarged. So MR, again, we see almost similar findings to that what we see in the CT. Here is an MR picture, which is again beautifully showing the peripheral pruning of the portal venous branches. Where MR stands out, however, is in the evaluation and characterization of liver nodules. So focal nodular hyperplasia is not uncommon in patients with NCPF, and MR imaging is useful for characterizing this. So this shows T1 hypointensity along with T2 hyperintensity for a focal nodular hyperplasia. In this particular patient, the MR was done for characterization of this liver nodule itself. So next we come to what are the findings on liver biopsy. So one thing is important about liver biopsy is that there are a plethora of findings. Not all will be seen in all patients. And these findings basically represent the response to the portal hypertension or the pre-sinusoidal block in these patients are not nothing very specific for an NCPF. And what is more important is the clinical picture and the biopsy correlate together to give you the diagnosis of NCPF. So what you classically see is an obliterative portal venopathy, which is seen in half the patients where you have a dilated main trunk with thick sclerosed walls and thrombosis of the medium and small portal vein branches. This is a hypoplastic portal vein that you see here, portal tract that you see here. Then there is a thickening of the wall. So in this particular image, you can see that this is the hepatic artery. And you can appreciate how thick the wall is of the arteriole. And here, this is the portal venule, and which has got the wall, which is of a similar thickness. These are paraportal shunts. So what are paraportal shunts? They are something like your intrahepatic collaterals. So just like you have extrahepatic collaterals, these are collaterals which open up to allow the portal vein to drain into the sinusoids because of the block. So this is another area which is showing your paraportal the paraportal shunt vessels. Then you can have portal venous dilation as seen here, megasinusoid dilated central veins. An important aspect is that the liver architecture, the lobular architecture is preserved here. You could have perisinusoidal and periportal fibrosis. Here, this is the Mason trichrome which is showing us with the periportal and perisinusoidal fibrosis. There may be incomplete septal cirrhosis. So the fibrous tracts start from your portal tract, but they are blind ending, they're curved, and they do not produce any regenerative. They do not enclose any nodules. There may also be certain amount of regenerative hyperplasia that may be seen. But the most important aspect is that studies have shown that liver biopsy may be completely normal also in 13% of patients. So patients with portal hypertension who have a normal liver biopsy, even that should ring a bell that we may be dealing with something like a non-cirrhotic portal fibrosis. Next, if we talk about the pressure measurements, the portal hemodynamics in patients with non-cirrhotic portal fibrosis. So here, the level of block is pre-sinusoidal. So your intrasplenic and portal pressures are high, intravascular pressures are high. The free hepatic pressure is obviously normal, but the wedged hepatic venous pressure cannot reflect the block, and therefore even that is normal. And your pressure gradient, which is measured as the difference between the wedged hepatic pressure and the free hepatic pressure, is usually normal or only mildly elevated, but never more than 10 millimeters of mercury in patients with non-cirrhotic portal fibrosis. Since it is known that these patients will have increased intrasplenic pressures and normal HPPGs, non-invasive tests of portal pressures like FibroScan have been utilized to look at the values in non-cirrhotic portal fibrosis. So in non-cirrhotic portal fibrosis, the liver is usually not stiff. In most cases, the LSM is less than 10 kilopascal. However, the spleen is quite stiff with a LSM of more than, the splenic stiffness of more than 25.4 kilopascal. So what you're essentially dealing with is a soft liver, but a hard spleen. Acoustic radiation force impulse, RF, is another form of elastography itself with similar findings. MR elastography has also been used, and again similar results. LSM less than 4.7 kilopascals and the ratio of splenic to liver stiffness of more than 1.23, which basically means spleen is stiff and liver is soft. And this has an area under the curve of 0.99 for the diagnosis of NCPF or idiopathic portal hypertension. So next we come to management. So what demands management in these patients? So one is variceal bleed. The second is splenomegaly. Patients can have ascites, portal vein thrombosis. Both of these are dealt medically. End-stage renal disease, end-stage liver disease would require a liver transplant. If we talk about variceal bleed, the options that are available to us are endotherapy, shunt, devascularization, TIPS, and other forms of endovascular therapy like PARTO and BARTO. Splenomegaly often results in pain, altered or impaired quality of life, especially in young adults, and symptomatic hypersplenism. Options available to treat splenomegaly are splenectomy with or without devascularization, partial splenic artery embolization. Newer techniques like high-intensity focused ultrasound or even irradiation are trying to find their way for management of splenomegaly. So I will not be dealing in depth about surgery because there's a talk tomorrow on the surgical procedures. But what we need to know here is that indications for surgery are variceal bleeding, splenomegaly with or without symptomatic hypersplenism, and end-stage liver disease. And why we need to know this is, as already discussed in the beginning, surgery is not something that is usually performed in cirrhotics. It's more or less contraindicated. They do not tolerate surgical procedures very well. Irrespective of procedure, they have a very high risk of decompensation, high perioperative mortalities, and high morbidities. Further, if you talk about shunt-induced encephalopathy would almost be universal in these patients, and therefore making an accurate diagnosis of whether you're dealing with a non-cirrhotic pathology or you're dealing with cirrhosis is very, very important in the management. So surgical options available are shunts. The primary indication for shunt is variceal bleed. You could do a non-selective or a selective shunt. Similar to what Dr. Richa spoke before me, selective shunts, the issue is that they do not address the large spleen, and NCPF spleens are massive, much bigger than that they're seen in EHPVO also. Shunts generally have been shown to have good long-term outcomes with reduction in the episodes of bleeding. And if you do a splenectomy, there's a 100% reversal of the hypersplenism also. The other option is to do a splenectomy with or without a devascularization and liver transplant if there is end-stage liver disease. But are all patients with NCPF candidates for shunt? So this is a paper which was published from AIIMS about 2 decades back, but very relevant. So they looked at these patients with non-cirrhotic portal fibrosis who did not have bleeding. 45 patients, 41 of these underwent a shunt. So none of them had a mortality, but at a median follow-up of 49 months, around 47% had some of the other morbidity with encephalopathy, glomerulonephritis, myelopathy, etc. Very low rate of bleeding post a shunt procedure. So they concluded that shunt was safe and effective in preventing variceal bleeding in NCPF, but this came at a very high cost of delayed morbidity. And the essential thing that it tried to tell is that if the patient doesn't have bleeding, then probably the risk of complications needs to be considered before offering such a patient shunt. Whereas a patient who has bled would actually benefit because of the stoppage of the bleeding episodes, and there the risk of complications may be justified. So this is another recent paper that looked at alternative option in patients to PSRS in patients who have non-cirrhotic portal fibrosis. They took 40 non-cirrhotic portal fibrosis patients who were non-bleeders and offered 24 of them splenectomy along with endotherapy in those who had high-risk varices, and 16 of them only shunt. So they found similar perioperative morbidity, no difference in the rates of upper GI bleed. Shunts obviously had a greater decrease in the grade of varices. Fifth of them got blocked, and about 12% of them went on to develop encephalopathy. As regards patients who underwent splenectomy, about 7% had thrombosis of the SP axis. And they concluded that since there was no difference in the rate of GI bleed and the similar perioperative morbidity, splenectomy with endotherapy was a good alternative to PSRS in non-bleeder patients with NCPF who had indications for surgery. Now, a word of caution here that even though most surgical series would give good results for splenectomy alone in patients with non-cirrhotic portal fibrosis, there is a realistic possibility of development of portal vein thrombosis following splenectomy alone, contributed both by reduction in the splenic inflow because of the splenectomy and compounded by the thrombocytosis that occurs following a splenectomy. Portal vein, because of these concerns, currently most of the guidelines would not more specifically, the APASL guidelines do not advocate offering splenectomy alone to patients with NCPF in the absence of a shunt procedure, and advocate dealing with the spleen with other options. However, other options are inferior to surgery in terms of their efficacy as well as the number of sessions needed and the recurrence of episodes of hypersplenism and complications. Now, if you look at the natural history of NCPF, earlier it was considered to be a completely benign non-progressive course. However, more recent literature has shown that it is probably gradually progressive, but still more or less runs a benign course. Decompensation is rare, and long-term studies have shown reasonable survival. Some at 5-year survival of 90%, 30-year survival of 55%. Some of the newest studies from the West have shown poorer long-term outcomes, but this could be contributed by the etiological basis. A lot of these patients have HIV, combined vascular immunodeficiency, etc., which could affect the survivals. Now, specific to patients with NCPF is they have higher rates of variceal bleeding, greater progression of varices. Even after endotherapy, a third of them will recur. What is more important is that what has come to light is a small proportion of patients actually behave like decompensated cirrhosis and end up requiring transplant. Uncommon events in the natural history of NCPF which occur but are not usual are portal biliopathy, thrombosis of the mesenterico-portal axis, with or without bowel ischemia, and splenic infarctions. Coming to portal vein thrombosis. Now, this is an important event in the natural history of NCPF. More often seen in NCPF compared to cirrhosis. Probability of developing portal vein thrombosis being about 40% at 10 years. Now, this could be completely asymptomatic when it happens, or because of the sudden rise in pressure, there could be variceal bleeding or ascites developing. However, what has been seen is that patients who develop portal vein thrombosis, irrespective of the cause, have worse outcomes compared to those who do not, which is why a splenectomy alone, which has a higher risk of producing portal vein thrombosis, is generally a lot of people would shy away from offering splenectomy alone. In the natural history, the stages are: 1, before the development of portal hypertension; 2, when portal hypertension just starts to develop but you do not have clinical features; 3, when you have overt clinical features like varices but there is no complication; and 4, once it has become complicated with bleeding, ascites, symptomatic hypersplenism, or end-stage liver disease. So, depending upon the stage at which the patient is, management options include monitoring, providing endotherapy or shunt or splenectomy, or in the end stage, a liver transplantation. Now, coming to the question of why do we need to differentiate it? Because there are 2 times when cirrhosis mimic each other. When the cirrhosis is in the early stage, so child age cirrhosis mimics NCPF, and when NCPF is in the end stage of liver disease, it mimics the decompensated liver disease. But as such, these are 2 different entities. In general, NCPF is believed to have a better long-term outcome than cirrhosis. Second, it has important implications on our management, not just whether you want to choose surgery or not for the patient, but if you have a distinct etiology like viral or alcoholic, removal of the etiology, treating the etiology could reverse or allow the decompensated patients to recompensate in case of in case of cirrhosis, and therefore it's important to make a distinction between the 2. If we look at all the data from various studies, what comes to the front is that most often NCPF patients present in the 3rd to 4th decade of life with an episode of well-tolerated upper GI bleed. Cirrhotic patients present a little later. Their episodes of bleed are not well tolerated. Liver function tests are essentially normal in patients with NCPF. They do not have jaundice, rarely ascites or transient ascites, only minimal hepatic encephalopathy. On the other hand, cirrhotic patients may present with jaundice, ascites, or overt hepatic encephalopathy. Spleen in NCPF is massive. To give you an idea, the average weight of a spleen in NCPF is about 1.5 kilograms, as opposed to about 700 grams in cirrhosis, which is roughly half of what you see in NCPF. So, another interesting study was published from PGI Chandigarh, where they used the technetium 99 labeled sulfur colloids liver scan. So, this is taken up by the reticuloendothelial system. In cirrhosis, because of the sinusoidal fibrosis, there is decrease in the uptake and there is relocation of this of the colloid to the bone marrow, whereas in the NCPF, there is a normal liver uptake without the shift of the colloid to the bone marrow. However, this is just a single study and this is not something that is routinely employed to differentiate between these two, but it's food for thought. If we look at the imaging findings that help us distinguish between cirrhosis and NCPF, this is a study, small study, 42 patients with biopsy-proven NCPF versus 42 child-day cirrhotics biopsy-proven. They found that certain findings which are more common in NCPF are extrahepatic portal venous thrombosis, intrahepatic portal vein abnormalities in the form of narrowing, reduced caliber, occlusive thrombosis, focal nodular regenerative hyperplasia like nodules and perfusion disorders. On the other hand, a nodular surface and hypertrophy of caudate lobe with atrophy of segment 4, which is part of the left lobe, was more frequently seen in patients with cirrhosis. Similarly, like we already saw, liver is soft in NCPF related to what it is seen in patients with cirrhosis. So on the basis of this, RFE was used to assess the liver stiffness, and it was found that patients with NCPF or idiopathic portal hypertension had a lower liver stiffness compared to cirrhotics, similar to chronic hepatitis patients, and more than that was seen in case of normal controls. So these were 20 in each category. Splenic stiffness in patients with non-cirrhotic portal fibrosis was more than all three categories of cirrhotics, chronic hepatitis, and normal controls. And when the ratio of spleen and liver stiffness was seen, it was more than that seen in cirrhotics or chronic hepatitis or patients with normal controls. And it was found that if an ROC curve was drawn for the spleen and liver stiffness ratio at a cutoff of 1.7, the area under the curve was 93 with a sensitivity of 94% and a specificity of 80%. And measuring the spleen to liver stiffness ratio by RFE may be a useful troubleshooting, non-invasive troubleshooting tool to diagnose non-cirrhotic portal fibrosis. This is a study from India, from Gangaram, which looked at the role of FibroScan. FibroScan is both FibroScan and RFE are basically a form of elastography. FibroScan is transient elastography and RFE is your shear wave elastography. So FibroScan, they found, was much lower in patients with NCPF with average values of about 6.8 kilopascal compared to cirrhotics who have a value of about 52.3 kilopascals. However, patients with NCPF had a higher value compared to healthy controls, whose normal value was about 4.7 kilopascals, and they found it to be a useful non-invasive tool to differentiate NCPF and child-day cirrhosis. Now, coming to HPPG, it's something that is not performed at all centers. And again, in an entity called as overlap NCPF, which we will discuss a little in a bit, it may be difficult to, its results may be inconclusive. But what has been seen is that, again similar to your measurements of FibroScan, non-cirrhotic patients will have HPPGs which are normal or mildly elevated. The mean in HPPG in non-cirrhotic portal fibrosis was 7.1, as opposed to cirrhotics who have a portal HPPG of 17 millimeters of mercury.
Ragini, you will have to conclude.
Yes, sir. Just reaching the end. So liver biopsy, again, important thing about liver biopsy is that it's a gold standard for cirrhosis, but it helps exclude cirrhosis, but it gives you only a suggestion of NCPF. Issues being it's invasive and it has got it's basically patchy, so it may be inconclusive. As already discussed, patients with NCPF have better outcomes in the long term compared to cirrhosis. However, recent data has suggested that there is a proportion of patients who end up with end-stage liver disease requiring transplant, and most of these would have a preoperative diagnosis of cirrhosis, and but the explant does not show any evidence of cirrhosis, and they may be candidates even in the absence of a diagnosis of cirrhosis for transplant. This is a study from Gangaram, which found that of 400 patients who underwent transplant, 10 patients had pure NCPF, and 10 patients had a combination of NCPF with chronic liver disease, and they found that patients with NCPF usually had lower MELD scores, lower BMIs, older than 50 years, and their indications were more of SBP or more of portal hypertensive complications like intractable ascites or HE with the relatively well-preserved hepatocellular function. To summarize, non-cirrhotic portal fibrosis is a form of non-cirrhotic portal hypertension characterized by sclerosis and obliteration of the medium-sized portal venous branches, leading to portal hypertension. Its etiology is poorly understood. The typical patient is a young male in his third to fourth decade of life with an upper GI bleed and a large spleen. They have preserved liver functions and therefore they have overall good long-term prognosis, but a small subset may may develop end-stage liver disease either as a result of persistent portal deprivation or superadded liver injury, to which these patients are more susceptible and may need liver transplantation. Thank you.
So, Ragini, I'll ask one question on behalf of the students that I have a patient who is bleeding and needs surgery. I'm thinking of a shunt, but I'm not sure whether it is compensated cirrhosis or NCPF, because if it is cirrhosis, I probably would not do a shunt, while if it is NCPF, I may do a shunt. So how do I go about it? Do you recommend a pre-op biopsy or intra-op biopsy and frozen section? How do I solve that dilemma?
So intra biopsy would not be a good way to go. So if the patient is acutely bleeding, obviously the first step would be to subject him to endotherapy. Emergency shunt would not be a very good idea, especially when we have a differential of a
This is an elective
So
situation.
if you are going to, if you have an elective patient, then we would need to take as already alluded to, a single feature is not sufficient to make a diagnosis. So everything starting from what is the age of the patient, what
Yeah,
is
so we've done all that. We are not sure whether it is NCPF or compensated cirrhosis. This is a very frequent.
A preoperative biopsy would be definitely useful in such a patient to rule out the presence of cirrhosis in these patients. And we do routinely get patients undergoing an HPPG and a TJLB at the same time, because most of these patients would also have thrombocytopenia. In the same sitting, we get the HPPG measurement, which also gives us a guidance that what we are dealing with, that's NCPF, and we get a liver biopsy, which then corroborates the findings of HPPG.
Piyush, any comments before we request Dr. Chetan to make his presentation?
So my practical suggestion would be that if you have a doubt between a child's cirrhosis versus a non-cirrhotic portal fibrosis, if you have a reasonable platelet count, liver biopsy preoperatively is an okay scenario. But if your platelet counts are low, and they often are in these patients, it becomes an issue trying to do a liver biopsy. A massive spleen is extremely uncommon in a patient with cirrhosis. You would get moderate sized spleens, you would get mildly enlarged spleens, but a massive spleen crossing the midline going into the right iliac fossa is something which would be a rarity. And in a patient who's 65 years old, I would not consider non-cirrhotic portal fibrosis to be etiology, especially if that is the age at which the patient is presenting to us. So some of these things could be useful in differentiating what is whether the patient we are dealing with has got cirrhosis or not. Liver biopsy, yes, if it is possible. You could use a fibroscan, may be helpful, but for us, the practical thing has been that we've used largely clinical features to differentiate between cirrhosis and non-cirrhotic portal fibrosis. If intraoperatively we felt that the liver was cirrhotic, we would take a wedge and a needle biopsy and go ahead and do a splenectomy and a devascularization rather than do a shunt procedure in these patients. So the practical utility of a lot of these investigations, you're still at the end of a number of these. The HPPG could help you, may not help you. A child's cirrhotic, you may still get a mildly elevated HPPG. So all these are not things that are going to be very clear cut. So that's where we would stand.
Okay. Thank you, Ragini. So now we move on to the last presentation of today, which is on portal cavernomatous cholangiopathy, which Dr. Peush felt that still should be called portal biliopathy. So Dr. Chetan, as I said in the beginning, is the chief of surgical gastroenterology at the KEM hospital in Mumbai. His team also has a fairly large experience with portal hypertension. So over to you, Dr. Chetan.
So can I share this screen?
Yes, please.
You have to enable it.
Sorry. Avinash, can you please make Dr. Chetan a co-host? Dwarka Clinic team?
Yes, sir, we are doing.
Yes.
Done, sir.
Yeah, okay. Yes.
So visible?
Yes, yes. Please go
Okay.
ahead. Please start.
Uh, so respected Kapoor sir, Dr. Sahni sir, and my co-presenters, I begin with acknowledging the fact that my co-presenters have done a very wonderful and exhaustive presentation. The topic of my today's presentation is portal biliopathy, or what is now called as portal cavernoma cholangiopathy. So if you see this particular pathology has had various nomenclatures over the years, beginning from Dr. Dilavri and Dr. Chawla terming it as a pseudo-sclerosing cholangitis, to pseudo-cholangiocarcinoma, to portal biliopathy, to cholangiopathy-associated portal hypertension, to portal hypertensive biliopathy, extrahepatic portal biliopathy, ischemic cholangiopathy, and portal ductopathy with portal cholangiopathy. Until in 2013, the INSR working team, they gave the terminology of portal cavernoma cholangiopathy. So the very fact that the nomenclature has undergone so many changes just underlines the fact that the pathology has undergone a lot of change in the understanding of its pathophysiology and what actually happens in this. So the INSAL defined portal biliopathy as, or portal cholangiopathy as abnormality in the extrahepatic biliary system, including the cystic duct and gallbladder, with or without abnormalities in the first and second generation of biliary ducts in a patient with portal cavernoma. So they gave a rider for it to be called as a portal biliopathy or portal cavernoma cholangiopathy. There had to be a presence of portal cavernoma, cholangiographic changes on ERCP or MRCP, and absence of other causes of this biliary changes like bile duct injury or ESC or cholangiocarcinoma. So the basic pathology in this is that there occurs compression of the bile ducts by the collaterals with or without ischemic changes, which are secondary to an altered biliary vascularization in a patient of extrahepatic portal vein obstruction. The good part is that around 77 to 99% of patients are asymptomatic, but there are 5 to 38% of patients who manifest with jaundice, cholangitis, cholecystitis, cholelithiasis, and abdominal pain. The risk factors for developing symptoms in patient of a portal cavernoma cholangiopathy are older age group patients, a long duration of EHPVO, dilated segments of bile ducts, and presence of gallstones and CBD stones. So these are the group of patients who have a risk of becoming symptomatic from asymptomatic. If one goes through the natural history of PCC, then it goes through from a preclinical stage to asymptomatic stage to becoming symptomatic and thereafter becoming complicated. So as I said, the caveat is that portal cavernoma has to be present in all. So it is present in all the 4 phases of its natural history. Cholangiopathy is absent in preclinical stage, whereas in asymptomatic stage, there are certain early changes which begin to occur. In symptomatic and complicated, these changes further advances. As far as liver biochemistry is concerned, in preclinical and asymptomatic stage, it is normal. In symptomatic and complicated, it will be obviously abnormal. As far as symptoms are concerned, they are absent in preclinical and asymptomatic stage, and in symptomatic and complicated stage, they are present. As far as complications are concerned, they are absent in preclinical, asymptomatic, and early symptomatic changes, whereas they are present when it becomes complicated. So as far as its classification is concerned, it's classified in various ways depending upon its pathogenesis. Shin's modification of original Demons classification is that it can be classified into varicoid type, where the obstruction to the bile duct is due to extrinsic compression, and the fibrotic type, where it is due to ischemia, and you have a third variant, which is mixed, that there is a combination of both varicoid and fibrotic type. Depending upon the ERCP findings, as per the classification by Dr. Chandra et al., it can be classified only in extrahepatic biliary dilatation or only in intrahepatic biliary dilatation, that is A and B type. In C type, you have an extrahepatic biliary dilatation with unilateral, either right or left intrahepatic biliary dilatation. And in D types, you have extrahepatic and bilateral intrahepatic duct dilatation. Depending upon the severity, as per Lop's classification, it can be classified into 3 grades. In grade 1, there is biliary tree irregularities or angulation. There is, in grade 2, there is indentation or strictures without dilatation. And in grade 3, there are strictures with dilatation. If it's intrahepatic duct, it should be more than 4 millimeters. And in extrahepatic duct, it should be more than 7 millimeters. The best modality for its diagnosis is MRCP with MR photography, and it can be termed as a gold standard for diagnosis of PCC. Now, this MRCP with MR photography helps us to assess both biliary and portal anatomy. One can see for the bile duct stenosis, angulations, dilatations, both extra and intrahepatic involvement, parietal irregularities, polydocal varices, and presence of stones. And further, it helps us also in deciding what is the best modality of treatment that we can offer to this particular patient. Now, the principle of therapeutic approach is most important is that treatment is recommended only for symptomatic patients. Patients with presence of biliary abnormalities associated with normal or abnormal biochemical alterations without clinical manifestation are not an indications for therapeutic intervention, but it just requires a biochemical and clinical follow-up. So this is very important, that you have to treat patients only who are symptomatic. You don't treat an asymptomatic patients. Now, as a surgeon, what we are concerned with is that we often get these patients of portal biliopathy who have undergone, referred by our GI medicine colleagues, who have undergone multiple times ERCP stenting and presenting either with complications or cholangitis. So how do we treat them? So that is a practical concern when these patients are referred to us. So as a surgeon, the challenges in these patients, so if you see in this diagram, this is the normal posterior superior pancreaticoduodenal artery, anterior superior pancreaticoduodenal artery, the gastrocolic trunk, and in the patients of portal vein obstruction or with the cavernoma, all these becomes dilated. So if this is overlapped clinically on a bile duct, it manifests as a dilatation or collaterals around the paracolloidal plexus, what is called as Petrin's plexus, or at the hilum, that is epicolloidal plexus, that is Saint's plexus. So these actually pose a challenge. They not only compress, but if you tend to operate on them, they pose a great surgical challenge to us surgeons. So these causes mechanical compression, mainly on the hepatic biliary duct and the common bile duct because of the collaterals. And if they remain for a long period of time, then they undergo ischemic changes, alter the vascularization, and lead to a mixed type of varices, that is both the fibrotic and varicoid type. So this is the intraoperative picture just to show you the collaterals and how very careful you have to be, because these really pose a challenge, and can lead to immense bleeding at time of surgery at times. So the principle of approaching this patient is our aim should be to reduce the portal hypertension first, and then to decompress the pericolodical collaterals. So this can be achieved by doing a photovenography, that is either a CT angiography or an MR angiography, and you look for the presence of shuntable veins. So you would see whether there is a patent and dilated splenic vein or a superior mesenteric vein, and also see for the renal vein whether it's normal anatomy or there is abnormality or is there any variations. And if there is suitable shuntable vessel present, then you do either a proximal splenorenal shunt, or if for some reason splenic vein is not good enough, the length is short, or if there are plaques, then you could also do a mesocaval shunt, provided the superior mesenteric vein is patent and good enough. So besides this, there are various other non-conventional shunts also being mentioned by various authors, including mesogonadal vein shunt or a mesorenal shunt or right photoovarian shunt or portal varix shunt. But important to note is that these are not the standard shunts. They are, as I said, unconventional shunts and should be done only in select subgroup of patients when you don't have a patent or a splenic vein or a SMV, which is superior mesenteric vein, which is not suitable for shunt. So these are not the standard shunts. These are the unconventional shunts, which have been done by few, but these are all anecdotal case reports. Now, if the portal cavernoma cholangiopathy or the bile duct obstruction is only because of the mechanical compression, then following a portosystemic shunt, following the shunting, the decompression occurs in the bile duct, and it can resolve both the portal hypertension as well as the obstructive jaundice at the same time. But unfortunately, this doesn't happen in all. If you intervene late in the natural history, or if there is ischemia which has already set in, causing ischemic changes in the bile duct, then you wait for 6 weeks, you give a stent-free trial and see whether the biliary decompression has been achieved or not. So you give a stent-free trial, and if the jaundice doesn't resolve, then it becomes indication for doing a surgical intervention to relieve biliary obstruction, where you would have to do a hepatico-jejunostomy. But unfortunately, things are not so simple that you always get a shuntable vessels. Many a times we come across a situation where you don't get a shuntable or a patent vein, and you cannot do unconventional shunt as well. So what can be done in this particular situation? So some authors have advocated doing a splenectomy with esophagogastric devascularization, where they have shown that it reduces the pericolodical collateral veins, pressure in the pericolodical collateral veins, and may at times improve the biliary system, or you can go in and do a biliary decompression later on. However, our experience with devascularization surgery in these patients have not been so great, though it has been mentioned by our Indian authors as well. Now, then you could also do an upfront intrahepatic segment 3 bypass. Again, let me tell you, it's very easily said than done. It's a definitive treatment for biliary decompression, and you can also do stone removal at same time, but it has its own complications because there are collaterals around the hilum, and it should be done very judiciously in a select subgroup of patients with caution. The third option is you can do an upfront single stage Roux-en-Y hepatico-jejunostomy. So many a times we get a reference from our medical colleagues to do this. But again, you have to be really brave heart to do this surgery because the patient bleeds torrentially. And though there are case reports with good outcome, let me tell you, they are anecdotal. You have to do 1 or 2 cases to experience what it is to operate on these patients. We have done so, and there are many a time on-table mortality due to severe bleeding. So this again should be done with a caution after counseling the patient and a very few select subgroup of patients. Now, liver transplantation. So this is a last resort in an uncommon surgical option for patients of end-stage liver disease due to cavernoma cholangiopathy. We know that secondary biliary cirrhosis, which ensues following this, is a known indication, but it is not possible in all due to difficulties in establishing the portal inflow, because as we know that the underlying pathology is portal vein obstruction, so you need to address that as well. So in this case, transplantation is not as easy as in other cases. So this is just a algorithm which I have made, that as far as the therapeutic approach is concerned, if a patient of PCC has a shuntable vessel, then you can do a portosystemic shunt in either form of PSRS or a mesocaval shunt. If not, then you may do a DVAS or a segment 3 bypass or upfront biliary decompression. But then again, as I said, very judiciously and in certain subgroup of patients. This is just our experience, where over the last 13 years, we have done 62 shunts for portal biliopathy, and of that 62, 46 patients further went to undergo biliary decompression. And I would like to end by overall algorithm for the management. So if a patient of portal biliopathy is symptomatic, if he is symptomatic for cholecystitis and polylithiasis alone, you should do cholecystectomy, again with a caution, with a very low threshold for doing a bailout procedure. If it's a varicose type of portal biliopathy in presence of cholangitis, then you have to do a first ERCP stenting. And once it resolves, and if the shuntable vessel is not present, then you can do a splenectomy. If it is present, a splenectomy with devascularization. And if the veins are patent, then you can do a shunt surgery and see for the decompression of the bile duct. If decompression occurs, you can remove the stent and follow up the patient. If decompression doesn't occur, then this patient after 6 weeks would require a bilioenteric anastomosis. In case of mixed type, you follow the same algorithm as we mentioned for the varicose type. In fibrotic type, again, if there is cholangitis, you first stent the patient. Then, if the shuntable vessels are present, you take up the patient for shunt surgery. If not present, then you may do either a DVAS or upfront surgeries. And after 6 weeks, because it's fibrotic type and ischemic changes have occurred, these patients will require biliary decompressions in form of hepatoprogenesis. Thank you very much for the patient hearing.
Dr. Chetan, for the benefit of students, I haven't read that paper, I think by Vishal and Abhijit. What is the physiological explanation that splenectomy and devascularization may take care of the portal biliopathy? I thought it would be the other way around.
What they have said, that paper has shown is that they have shown that the collaterals get decompressed, and they have shown that the pressure actually decreases. And if you have intervened early, then some group of patients may not require a biliary drainage at all. But that has not been our experience. That is the only paper which shows that you can do a DVAS in these group of patients. That is why I said that though it has been mentioned, our experience has been totally different. It doesn't happen so.
Because splenectomy alone, I may understand that the flow is decreased. But then if you are doing it for portal biliopathy, I would not devascularize because they are the shunting collateral.
Exactly.
I probably would do only a splenectomy.
Right. So,
yes.
So that is why, sir, because that is what I said, that though there is a single paper and it's a paper from our country, our experience has been otherwise, in fact. So we wouldn't actually embark on doing a devascularization surgery. So that is not means we wouldn't advocate doing that.
And before I hand over to Peush, one more question which you and Richa both can maybe take. So I have a patient with EHPVO who otherwise doesn't require surgery because of the spleen or because of the bleed, but there is documented portal biliopathy, but it is asymptomatic. Now, Richa has been teaching us for several years that in these patients, it is easier to do shunt when they are young. As they grow older, the splenectomy becomes very demanding. And now she said that even the shunt may become more demanding. And we know that without a decompression, portal biliopathy is not going to resolve on its own. Either it will stay as it is or it will progress. So does a definite evidence of portal biliopathy, even if it is asymptomatic, not causing cholangitis, become an indication for a shunt?
So, sir, should I take this question first?
Yeah,
Because I
please.
was wanting to ask this from Dr. Chetan. Maybe the
You are
pediatric.
not here to ask, Richa. You are here to reply. Yeah.
So it is a discussion, sir. So
Okay.
actually,
Yeah.
sir, the pediatric surgical experience may be a little different from adult experience. One, I want to say that portal cavernoma cholangiopathy is increasingly being recognized in the pediatric age group as well. It is not unrecognized, and children as young as 6 years of age have been reported to have symptomatic portal cavernoma cholangiopathy, and children as young as 11 years of age have been reported to have secondary biliary cirrhosis. And in our published data, 139 consecutive children of EHPVO whom we operated surgically, 7 of them, the indication for surgery was portal cavernoma cholangiopathy, and one child at the age of 10 years actually had secondary biliary cirrhosis. So actually, our pediatric gastroenterology team, thankfully, was very much pro-surgery. Dr. Yacha was very much pro-surgery. And therefore, if we, one, that at the time of initial presentation, it was a part of the protocol that every patient should have a liver function test, including GGTP. That is a screening test for screening test to make sure that this patient does not have portal cavernoma cholangiopathy. We may not do an MRCP for every patient, but we would do an LFT with GGTP. Now, over a period of time, because we realize that by the time the patient becomes symptomatic with cholangitis and jaundice and pruritus, many of them may have fixed strictures, and doing a shunt alone may not relieve biliary obstruction, and doing a biliary drainage procedure in them surgically is any surgeon's nightmare, as Dr. Chetan showed. Therefore, we at SGPGI, and also there is an article by Willers et al. Exclusively on pediatric patients, felt that even if a patient had significantly elevated GGTP and a shuntable anatomy, we would offer a shunt electively to this patient, because at this stage one could expect reversal of LFT, and we could actually prevent progression to a fixed stricture and secondary biliary cirrhosis, etc., etc. So, so we have a small series of 7 cases with portal cavernoma cholangiopathy, wherein we did a shunt. We have not done hepatogenostomy in any. Of these 7 cases, one of them, the indication for surgery was just persistently elevated significant GGTP. And he did not even have splenomegaly-related issues. His varices were eradicated endoscopically. We did a side-to-side splenorenal shunt, and his LFT normalized. So,
Chetan?
So I'll give you
I
my
don't really
view.
have a final answer on this. So maybe, Dr. Peush and Dr.
Yeah,
Chetan.
Dr. Peush will have the final word. But my logic is like this. I too am very pro-surgery. According to me, if you go through the natural history of PCC, all these patients eventually would become symptomatic. And I feel that they should be intervened early so that they may not require hepaticoagulation. Because if you intervene early when they are in varicoid stage, then by doing a shunt, you decompress and the mechanical obstruction on the bile duct gets removed and you don't. So I'm very pro this. But the standard teaching is that you don't operate unless it becomes, unless they become symptomatic. So many a times in a younger age group patients, we personally, we have intervened even though they have been asymptomatic, much to against the resistance of my colleagues who say that we should be doing only if they are symptomatic. But I am pro intervening early if they present to me early with portal biliopathy, with altered LFT, even if they are asymptomatic, I am for surgery. I don't know what is Dr. Peush Sahni's state, because we have discussed this many a times with him.
Yeah, Piyush.
So I'm totally for operating on these patients early. So we won't go only by ALK-Phos and GGT. I think we would look at the transaminases as well. And if there is mild transaminitis or any evidence of the transaminitis showing an upward trend, then certainly these patients should be intervened on. I would much rather that a gastroenterologist, endoscopist not put in a stent into these patients for whatever reason. Because once that stent goes in, it's practically impossible to get them to get a stent out. Because they're so reluctant to take it out, because every time they feel that if they take it out and they need to put back a stent, it'll be another difficult endoscopy and stenting for them. So it's a challenge to get them to remove stents, and it's a challenge to get them to not put in a stent in the first place. We did a small case control kind of study. We presented it at a conference, but unfortunately didn't get around to publishing it. We found a relationship between age and the use of endotherapy. So variceal obliteration endoscopically both seem to be risk factors for the occurrence of portal biliopathy. Now, the study was a small study, and we could actually do a larger study, but somehow we didn't get around to doing it. But that small case control study suggested that these two things were important. We haven't gathered data on whether a patient who has a high alkaline phosphatase, a high GGT, a high a 2 or 3 times or 4 times elevation in the AST, ALT goes on to develop in the natural course portal biliopathy, which is symptomatic over a long period of time. But I have no doubt in my mind that the earlier we get to them and the earlier we intervene, the more likely we are to not see the bad symptomatic ischemic strictures that we see in patients with portal biliopathy. So I am totally for doing, and for us, doing primary prophylaxis is a yes for extrahepatic portal venous obstruction. And we believe that we don't need to wait for anybody who has high-grade varices, has a large spleen, has portal biliopathy evidenced by arising transaminases or even arising alkaline phosphatase should be subjected to primary prophylaxis in the form of a central splenorenal shunt. We published a paper. We didn't use portal biliopathy as an indication there, but I have no doubt that that too will work for these patients.
So
Yes.
can I just to highlight the complex, sir said that these patients should not be actually stented by gastroenterologists. We have had lots of complications with stents, including stent perforation. And in one interesting case, which we did about 3 months back, is that the endoscopist had stented a varix and patient had severe bleeding. He thought that it was such a big varix, he thought that it's a bile duct. And he actually he stented the varix, or he went through the varix, and with stent in C2, he shifted the patient to us. And then we managed her initially conservatively because the bleeding fortunately stopped, because the stent itself acted as it gave a compression. And then we went in and did a shunt surgery, and at a later stage, we removed the stent and did a pelvic bypass. So such complications we do come across.
A frequent clinical problem is that we have significant symptomatic portal biliopathy which requires intervention, but there is no shuntable anatomy. Now, in this situation, one option is to follow what the KGMU group has said, that we do a splenectomy devascularization. Although personally, I haven't read that paper, but in general, I have my reservations about it. And the second option you said is segment 3, which again is a technically demanding procedure, and there could be collaterals there also. So between any of these or a direct access to the bile duct without a prior shunt, so any of these versus a long-term definitive management with a covered stent. Now, covered stent at that point, the endoscopists are not very keen because it will block the pancreatic duct. And although covered stents, for the sake of students, are being used as a treatment of esophageal varices because they provide compression. But in this situation, so how, suppose tomorrow you have a patient like this, what would be your approach?
So it's not very uncommon to be in this situation, sir. So we basically take into consideration what is the patient's age. If he's a very young patient, he cannot be going on getting stented repeatedly, and he cannot be with a covered stent for a long time because sometime or the other it's going to get blocked still, and you will have to remove. So in this patients, after adequate counseling, we do operate on these patients. We have up till now operated 9 patients. We have lost 1 patient in initial this, but the others, they bleed profusely because by the time you reach the bile duct, they're such thick that every time you take a stitch and it bleeds so profusely. But then you take multiple sutures and just then you make it can be done. It's doable, but then it bleeds a lot, and you have to really be very patient, and your anesthetist has to be also very good.
Only thing I would say that since students and young surgeons at various levels of expertise and experience would be watching this, that this procedure, that means direct access to the duct without a prior shunt, has to be done, should be done, must be done in a center which has
Tertiary reference center.
experience with these cases. It's as I call it, this is one of the Waterloos where any surgical Napoleon can lose the battle.
Absolutely, absolutely.
Piyush, you wanted to say something.
So 2-3 things that I'd like to add. First and foremost, if you have a situation where you think you have a large collateral, take the option of doing a makeshift shunt. You need the makeshift shunt patent for that 6, 8, 10, 12 weeks, whatever period of time you want the portal pressure to come down. And it has worked in some situations where we've done it. The numbers are not large, so therefore I'm not quoting data, but the numbers are 2, 3, 4. But you know, those numbers are adequate for those patients. For that individual patient, that makeshift shunt works.
I think Biju also has published, and SGPGI group also published on makeshift shunts. Yes.
So that's one. The second is if you have no other choice but to go in and offer a direct approach to the biliary tree, do 2 things. One, start them on terlipressin and get the portal pressure down intraoperatively. And the second is get your anesthetist to use hypotensive anesthesia. Now, however they do it is their choice. We found sodium nitroprusside to be a very good thing, and we've published this previously. But whatever way, if you get the blood pressures on the slightly lower side, then you tend to lose a little less blood. Third and most important, have a number of blood transfusions or a blood loss cutoff in your mind where you will say, I will withdraw my hand and live to fight another day, rather than be foolhardy and go on and on because, you know, it hurts your ego to come back and say, no, I've not been able to do it. So if we were to go in, we would explain to the relatives, to the patient, if the patient was an adult, that look, it is possible that we do this dangerous surgery and it is possible that we may not be able to achieve anything. But we would then live to fight another day. If they're symptomatic, if they're getting recurrent episodes of cholangitis and this fails, then we would have no choice but to put in a stent. You could do it percutaneously, you could do it endoscopically, whichever way you wish to do it, and leave that stent in situ for a while and then see if you can fight another day. We've had a few situations where we've attempted a hepaticojejunostomy, not succeeded, had the patient remain asymptomatic, and gone in again and attempted hepaticojejunostomy, it succeeded. Again, these numbers are small, 2, 3, 4. So therefore, again, I'm not quoting data here, but it works in that situation where you need to go back in again. There are again a small number of patients in whom we put in a stent, let the cholangitis get resolved because they've had bad cholangitis and gone ahead and relieved them.
We have just 1 more minute. So Richa and
Sir,
Chetan.
sir, at this point, sir, I would like to ask Dr. Peush Sahni's take on what is the role of cholecystojejunostomy in these patients?
So we've never done it, and to my mind, it will not work unless your MRCP shows you that the bile duct is dilated till the level of beyond the hilum. Because if that is so, you have a confluence patent and the bile duct, the common hepatic duct patent, then you could attempt a cholecystojejunostomy and may work. But if the block is slightly higher up, if there is a right, left-sided separate involvement, then it's unlikely to work. We've never done it.
We did it 2 of our patients. In one patient, it seems to be working. And another, the bilirubin is still at a higher level.
Yeah, Richa, any last minute?
Sir, I had a comment and a question. My question to all the 3 senior hepatobiliary surgeons is that if portal cavernoma cholangiopathy is the main indication for surgery and both the splenic vein and the superior mesenteric vein are shuntable, then would you, which one decompresses the PCC better, a mesocaval shunt or a splenorenal shunt? Because as far as the understanding of the anatomy goes, the veins of the biliary system, they drain more directly into the SMV as compared to the splenic vein.
Both are total shunts. Both should do the same. That's what I think. Piyush?
So we prefer to do the to do a PSRS for the simple reason that the shunt patency rate of a PSRS is higher than that of a mesocaval shunt in our hands, and therefore the likelihood that we will be able to decrease the portal pressure and be able to do a decent decompression would work better. In a situation where we don't have a splenic vein available, we would choose a mesocaval shunt with an autologous graft.
Thank you, sir.
Okay,
And
I think
the comment was that if the splenic vein and the superior mesenteric vein both are thrombosed, but the inferior mesenteric vein is patent, then sometimes one can use that for a shunt in a
Correct.
situation like this.
Anyway. So we have a tradition to start at 7 and close at 9. So I would like to take this opportunity to thank Piyush, thank all the 3 speakers, Richa, Ragini, and Dr. Chetan, and thank Avinash for his team's technical support for all the online JST activities. And hope to see you all tomorrow, even those who are not speakers. If you are free, please join in for your inputs. So see you tomorrow at 7.
Thank you very much.
Thank you,
Good
sir.
night.
Thank
Good night.
you.
We
Thank
will
you so
close
Thank you,
much.
sir.
the
Good
session.
night.
Thank you.